Hello everyone, I'm Dr. Akshay Baheti and welcome to the Cafe Roentgen Journal Watch. This time we are going to discuss how to prepare our radiology department or imaging center for the next 2 weeks of lockdown and more importantly for the post-lockdown stage when patients will start coming back to us. And indeed, preparedness is the key for us to be able to negotiate this as safely as possible. I think we all have to realize that right now we are in this scenario where we are performing only emergency services and COVID response during the lockdown. However, post lockdown, we expect patient volumes to rise, all the postponed appointments to then come back, and probably there will be higher volumes which will happen post lockdown. One more scenario which we have to worry about is that these higher volumes and the overall post lockdown scenario might actually lead to a higher transmission of COVID 19 and lead to a New York like situation where our health system is overburdened with cases. And if that happens again, this cycle may repeat. So we have to prepare in our minds for all these three scenarios as we move ahead. And of course, while preparedness might be slightly different for imaging centers and hospitals, the fact is that we all have to start sometime or the other. This is a long drawn battle and it's not going to get over anytime soon. So the first thing you have to do is review our current infrastructure. If we are a hospital setting, then understand that portable machine use will increase. Obviously, a lot of portable x-rays will be done and perhaps portable ultrasounds will also increase because portable machines can be easily disinfected. Um, as far as CT is concerned, ideally, actually, we need three separate machines, one for COVID patients, one for suspect COVID, one for non-COVID. Obviously, this is not practical. If a hospital or imaging center has two machines, then use one for COVID and suspect COVID patients and one for non-COVID patients. If we have only one machine, just do the scans carefully and obviously disinfect after every patient, particularly for any suspect patient. Um, Work on teleradiology abilities during the next 2 weeks of lockdown. We will all have to work as much as possible from home. So we have to work on improving our teleradiology abilities. And of course, work on creating SOPs for mass, disinfection, fumigation, etc. This lecture is not going to cover that much. We also have to understand that air conditioning is important. And if it's a central air conditioning, then microbes or viruses in one room might actually get transferred to another room. So ideally, we should try to avoid central air conditioning and instead convert to split ACs or something like that, particularly in imaging centers. In larger hospitals, this may not be possible, but there are other turnarounds which you'll have to read and discuss. What about patient scheduling and patient waiting area? Right now, obviously, we are going to schedule only urgent and probably semi-urgent scans like cancer staging and are postponing all elective scans. No screening studies are currently performed, so no screening mammograms or DEXA scans, etc. And as far as possible, we have to avoid any relatives as long as the patient is stable. Post lockdown, obviously, I think slowly the volume of patients will increase and we'll end up doing a lot of elective scans as well. Most important is to communicate with the referring physician and with the patient. So you have to understand the indication for doing the study, particularly in the lockdown scenario, and do only what is necessary. Also, we need to discuss with the patient if it's an elective patient or patient who's coming after an appointment, particularly in the post-lockdown setting, so that we explain to them that no relatives are required as long as the patient is stable and they will not be allowed inside the waiting area, and also explain to the patient the need of wearing a mask. At the entry point, we have to screen for symptoms. So fever, cough, breathlessness, anosmia, these are common symptoms. Use the infrared device for checking for temperature. Every patient has to have a mask, at least a cloth mask. And if it's a symptomatic patient, then certainly a surgical mask. We should triage patients right at the entry. So any symptomatic patient, take the patient right away, do the scan and get the patient out as soon as possible. If it's an older patient, then preferably do such older patients or patients with comorbidities first so that they're less exposed to the hospital or imaging center environment. Social distancing is extremely important at the waiting area. Try to put a glass barrier between the help desk or the staff and the patient so that there is less scope for exposure. And I think most of us will be using something like these to ensure that patients remain at some distance away from each other. A patient and the patient's relative, if the relative is also inside, can stay together. But two sets of different individuals from different settings have to stay 6 feet away at least. And we have to redesign your waiting area in that fashion. So maybe alternate seats should be used or something like that. While scanning, we have to be very fast and efficient. Try to do focused abbreviated scans, particularly for MRI, where we often take extra sequences which can be reduced in this scenario. We must minimize the interaction between the tech and the patient. So the tech should start verbally explaining to the patient how to position so that they need not touch the patient or get in close contact with the patient. We have to stagger appointment timings very properly and keep the outside waiting area crowd to minimal. So ideally, perhaps just 1 or 2 sets of the next patient should be in the waiting area, depending on how large the waiting area is. And the others should be called at later timings, or perhaps be waiting outside the door if possible. If we, God forbid, reach a situation where the system is overloaded by COVID patients, then this is what is done in some of the New York hospitals nowadays. Any requisition is coded by the referring physician, either critical, which has to be done right away, semi-urgent, which can be done in 1 or 2 weeks, something like a cancer staging or restaging, and non-urgent, which can be done at a later date. We have to reorganize reporting as well. So obviously work on a staggered work schedule so that not everyone needs to work every day. You may think of allowing high-risk radiologists to do teleradiology. Perhaps let the younger and lower-risk radiologists perform the ultrasounds. Similarly, techs also have to be reorganized. So younger technicians who are in CT or MRI may actually be asked to do portable X-rays instead in a hospital setting because they are safer. And we must try to ensure physical distancing in reporting rooms as well. So ideally, ensure that each workstation is for a particular radiologist, and try to ensure a distance between 2 workstations is much more than 2 meters, I would say. As far as work scheduling is concerned, try to create 2 or 3 completely independent batches. And when I say batches, it's not just radiologists, but also technicians, nurses, etc. So that there's absolutely no overlap. In this case, it will be safer because if one of them gets a COVID positive test, then there's an entire separate safe batch who can continue working, and this will avoid the center being shut down. So if this is feasible in your situation, certainly do that. A lot of people are now talking of doing 6 to 8 hourly shifts rather than longer shifts because of the risk of higher exposure or exposure to higher viral loads as the duration of shift increases. But this is more true for ICU and COVID isolation ward settings. As far as radiology is concerned, we should not worry about that, and we can go ahead with doing longer shifts as well, particularly if this allows us to work on an alternate day schedule. We must realize that while we create a schedule, they will be flexible, and it is possible that in the future some healthcare workers in our institute or center may get affected, which may reduce the workforce, and then people have to be agreeable to work in out of turn. As far as workspace safety is concerned, obviously you need to allow alcohol or hand wash to be present at the entry. Try to convert all your doors to automated doors, or at least doors which open both ways so that they can be pushed open by elbows or feet instead of having a doorknob which is needing to be touched. Redesign washrooms so that again you use automated taps and stuff like that so that high touch surfaces are reduced. Avoid eating at common spaces like eating areas. Microwaves example is another high touch surface. So avoid using such common areas. Obviously disinfect high touch surfaces. There's no definite guideline. The guideline actually says disinfect every 24 hours, but I would actually say disinfect every 4 to 6 hours at least. And disinfect your workspace yourself. So always assume that no one has done the job perfectly for your workspace. So when you come to the workstation, take an alcohol wipe or a Clorox wipe or something like that. Clean the entire keyboard, mouse, telephone, dialing pad of the telephone, the armrests of the chair and your desk completely. So that is disinfected. You have to create proper SOPs for performing X-ray, ultrasound, CT, intervention, etc. of COVID patients or suspect COVID patients. Donning and doffing of PP is not an easy task at all. Even doctors often find it difficult to do it properly. So we have to train not just ourselves, but especially the technicians to do it properly. Also train the technicians and the doctors to disinfect machines, workstations, etc. properly. And have clear-cut SOPs and guidelines on when to isolate or quarantine. It has to be something we do in advance rather than post facto. So that if a certain healthcare worker in your facility gets detected with COVID-19, it should not happen that everyone else gets isolated or quarantined, even though many of them are not really exposed for long periods of time. Do mock drills, do a mock drill of how to perform an X-ray, etc., so that everyone is aware. A lot of webinars are being carried out every day for online training, etc. And if we do all that, I think we should be much better prepared. Remember, this is a long haul. There's no getting away from it. COVID-19 is here to stay for months or even longer. And we all have to eventually get back to our workspace sometime. Of course, things are evolving very rapidly. So keep yourselves updated. This knowledge will probably need to be updated every day or every week at least. I'm finishing off with this lovely photo of a leopard at a place called Bera in Rajasthan, which has India's highest density of leopards. I went there in February just before the corona crisis began. So hopefully something to remind us that nicer times will be ahead, hopefully soon. Thanks a lot.